accurate and up-to-date refraction. So just a word of caution before you start doing your binocular vision workup. Just be careful to take a full patient history to rule out any possible pathology from something that's more functional in nature. So for example, any headaches that do not correlate with binocular vision anomalies. Maybe the patient's waking up with intense headaches, having nausea, vomiting. These don't make sense with the headaches that occur more as a result of reading all day. Might be more linked with, say, something called convergence insufficiency. Just always be careful to take a full patient history. Also highly recommended to complete a dilated ocular health assessment first, just to be on the safe side. Usually we'll do some more basic binocular vision tests. Maybe we're thinking there's an issue. They have a full comprehensive dilated eye exam and then come back for more binocular vision testing if needed. And again, always an updated and accurate glasses prescription. So I'm going to be going into our first topic of the day, cover test. We're teaching you the cover, uncover, and alternating cover test to rule out aphoria versus atropia and get a better understanding of the patient's eye alignment. So what are aphorias and tropias? Aphoria is the position of the eyes when binocularity is disassociated. This is sometimes referred to as the eye's resting position. Disassociation eliminates fusional vergence for the patient. You can do this in a couple different ways, either occlusion or prism. And this essentially disassociates the eyes by presenting images that are unfusible. And then the eyes go to that resting position. In contrast, atropia is a misalignment of the eyes when a fusible image is presented. So patients should be able to fuse this image, but for whatever reason, they are not. A word of caution or of note, since binocularity is impaired in patients with strabismus or atropia, you often cannot perform binocular vision testings because the patients are not binocular. So just always remember that if you're doing your cover-on-cover test, finding atropia, probably won't be able to measure vergences in PC and the other testing I'm going to present today. With that said, there is a caveat that it's important to remember that tropias can be variable by the time of day, length of testing, and near work. So again, careful case history. If it's a more intermittent tropia, you might be able to perform some binocular vision testing. You may not. So cover test procedure. The purpose of this test is to determine if a patient has aphoria or atropia and the characteristics of that tropia when present. It's objective, can be performed quickly and easily on most patients. This is a very good screening test. It's done in almost every comprehensive exam. And this test can also be used to measure the ACA ratio, and I'll again go into more depth with that later. So one of the crucial components of the cover test is controlling accommodation. We need to select a proper target. So accommodation affects vergence, which then affects eye alignment. So there's that near triad of pupil size, convergence, and accommodation that are linked. So our eyes converge, accommodate, and our pupils become smaller. All those three things are linked. So to control accommodation during the cover test, we need to choose a properly sized target, have the patient attend to that target, and keep it clear. So it's just very important when you're performing this test to stress, can you see that target? Can you keep it clear? You might have them keep reading the next letter if they're doing this test at near. For children, there's often lots of little targets where they can see little animals, and you can ask little questions about that. Oh, what color is the chicken? What color is the alligator? And things like that. The reason we want to do this is because that can change, under or over accommodation can change the aphoria position. For example, under accommodation will overestimate an exophoria, and over accommodation will underestimate an exo. So just be aware that It's important to constantly keep stressing, can you see the target, and keep it clear. So what are our options for targets? So for distance and near target cover testing, we use that accommodative target. We're going to select a target size around 20/30. That for a patient that's 20/20, that's usually 1 to 2 lines above the best corrected visual acuity in the poor seeing eye. So if your poor seeing eye is, say, seeing 20/40, we're going to have to select a target that's more 20/50, 20/60. It's ideal to keep the fixation target isolated, particularly at distance. This is a great distance target here. We're isolating the E. We, again, need to always stress that the patient keeps the target clear. Here's some near sticks here at the bottom with more pictures that you can use in children. I also have an example here that you can use with the different letters and a different target size. So you might have them focus on one letter there at the bottom when you're performing this. You can also have them read the rest of the letters, so you're ensuring that they're keeping the target clear. So how do we set up this test? The patient is going to wear the habitual correction for the distance you're testing. So their distance glasses, if they take those glasses off when they're reading, that's how you want to test them. Or if they wear glasses full time, you want to have them wear their glasses all the time. You're going to be eye level with the patient and behind the target as much as possible for near testing. So it's ideal if you're doing this test or right behind it, you're watching the patient's eyes. For the distance target, you don't want to get in the way of the target, so you need to be off to the side, but still as straight as possible. And we always need to have good lighting to maximize contrast on the target and to pick up any small ocular movements. So first step is the cover-uncover test. We're always going, the whole purpose of this test is to determine which eye is fixating. So how do we perform this test? We're having my patient look at the target. I'm going to pretend I'm looking at a target in the distance. You're going to cover the right eye with the paddle, pausing for 3 full seconds. 1, 2, 3. You're going to uncover and watch for the eye to move to fixate. Again, 1, 2, 3. Good. We're going to repeat that procedure twice before switching to the left eye. If neither eye moves on that cover-uncover test, then we're going to proceed to the alternating cover test. So some examples here on the diagram. So we have our patient here. Just looking at the patient, they look like they might have an eye that's a little in here on the left, an eye that's a little out here on the right, on the left as well here at the bottom. This is more of an esotropia. This is an exotropia. And we go to do cover test. So we're covering the right eye. When we cover the right eye, we notice that there's movement out of that left eye. So that eye was in, it's moving out. So that means that eye was an esotropia. Here at the bottom, we're covering the right eye. When we cover that right eye, this eye that was out previously is now moving into fixate. So that means it was out, moving into fixate. That was an exotropia. Here at the bottom, we have a patient that looks a little bit more ortho to start with. We're covering the left eye here. And whenever we uncover that eye, the eye moves out. And so that means the eye was in. And here on the bottom is just the reverse. We're covering the eye. When we uncover it, the eye is moving in. That means the eye was out previously. This takes quite a bit of practice. Just watch which eye is moving out. If neither eye moves, that means both eyes are fixating on the cover-uncover test, and the patient does not have atropia, and we're going to move to the alternating cover test. So on the alternating cover test, what we're going to do is we're going to move the occluder quickly between the two eyes while keeping each eye individually covered for 3 seconds. This is going to keep the eyes disassociated, disrupt that fusional divergence and allow the eyes to go to their Fourier positions. So it's going to be 1, 2, 3, 1, 2, 3, 1, 2, 3. And we're going to watch for any eye movement. So the eye that is not occluded is going to fixate on the target, while the other eye will go to its Fourier position. So here we have 2 eyes straight ahead. Covering the left eye, you can see behind this little magic occluder here that the eye is a little bit in. When we move that occluder over to the right eye, this eye right here is moving out a little bit, so that means it was in, it's moving out. We're covering this eye, we can see again behind my magic occluder that this is in. When we move it over to the left eye, that eye goes out again. This eye is in again. So essentially when we're covering it, the eye is in, that's its resting position because it's disassociated, and the eye flicks out when it's uncovered. So they're flicking in, they're working together in Fouriers. Both eyes are moving together, and this is an example of an esophoria. So if thinking about cover analysis, if an eye moves to fixate during the cover-uncover test, then that patient has atropia. For tropias, we need 4 different components. We need the laterality, left, right, or alternating. Since it's always in the left eye, is it always in the right eye? Do you see uncover test, the eye moving out in the left or in the right? That's more of an alternating laterality. We also need to know the frequency. Is that tropia always there, or is it intermittent? Also need to know the magnitude, which you can do by 2 methods. You can neutralize with prism bars or loose prism lenses. And when you get more experience, you can also learn how to estimate the magnitude. We also need to know the direction. Is it hyper, hypo, is it exo, or is it eso? Okay. So if the eyes do not move during cover-uncover, but do with the alternating cover test, that means we're dealing with aphoria, and we only need 2 components when we're recording and looking at aphoria. We need the magnitude and the direction. So I'm going to show you a video on the cover test.